Onc Live Insights is a video editorial program produced by Onc Live.
At our center at the Dana-Farber, we start with testing for RAS, and if you're RAS wild type, we then do testing for BRAF. We don't routinely do BRAF testing if you're a RAS mutant. Why? Because what we realize is they're virtually mutually exclusive. Tumors that are RAS mutated are rarely BRAF mutated and vice versa. So we do it sequentially just to reduce cost. But we do it on everybody. It's important. We know that patients whose tumors are BRAF mutated have a significantly worse survival. Moreover, we know that there's a variety of new drug trials directed at BRAF mutated patients that seem to have benefit. They're complex. They're not as simple as just using a RAF inhibitor. They often require a RAF inhibitor plus a MEK inhibitor plus an EGFR antibody. But if you combine those three drugs, we're seeing really significant responses in patients.
BRAF testing, I believe, should be done on all the patients up front. We know that BRAF is not a predictive marker per se to EGFR drop, but we know it is a prognostic factor. Patients with BRAF mutations tend to do worse than a patient with BRAF wild type. So if you look at the TRIBE study where they looked at FOLFOXIRI in that setting, patients with BRAF mutation had overall survival of only 12 months. Therefore, if you know that patient is BRAF mutant, we know that overall survival should be much shorter, so you don't have time to give first, second, third, or fourth line therapy. So having the data up front will tell me that overall this patient will have a much worse prognosis. Therefore, I want to be more aggressive with this patient. So in the TRIBE study, when they looked at the subset analysis, actually FOLFOXIRI benefited in patients with BRAF mutant compared to FOLFIRI alone. So those are the patients that I would actually use more aggressive therapy, such as FOLFOXIRI up front, knowing that I don't have a long time to treat the patient.
Most people don't look at BRAF results. Sometimes they're not given out. In our hospital laboratory, the BRAF test is available if you want it. There's no extra charge. It's already part of the package. But they only give you what you ask for. I like to see the BRAF results for two reasons. One is that it is clearly a marker of poor prognosis. And I think when one is talking to a patient about their treatment, if in their mind they know enough to read and they've read about 3-year survivals in metastatic colorectal cancer, that's a best case scenario. That's a case from patients selected for clinical trials, who are eligible for clinical trials, who are all KRAS wild type and very few BRAF mutants. If you look at pure BRAF populations, BRAF mutant populations, it's not a predictive marker. Those patients do benefit from EGFR inhibitors, but to a much less degree, both relatively and absolutely. And overall, the median survival, even with all the available drugs we have in the United States, is just in excess of a year. So I think it's a responsibility of a physician to do two things. Talk about cost of therapy with patients. Don't pretend that drugs are not expensive or what the cost is that they might be paying for it. And don't lead them down the wrong pathway in terms of the tumor they actually have, not what is reported in the literature. I think there are many ways that a doc can introduce that without being overly morbid or coercive. There is currently a phase 2 trial. Scott Kopetz is doing this at MD Anderson. It's being done through the cooperative groups. And what this looks at is based on laboratory data that shows that a combinatorial approach of adding an EGFR agent, cetuximab, to vemurafenib, a BRAF inhibitor, may restore the effectiveness, if you will, or allow the effectiveness of the BRAF inhibitor by blocking some of these salvage pathways that occur in colorectal tumors that don't seem to occur in melanoma.